Okay, good.
Good evening, everyone. My name is Tracy Sharon, and I am the CEO of the Saskatchewan Health Quality Council. It's my pleasure to welcome you to our session this evening. The Health Quality Council is an independent agency committed to bringing about better health and health care for Saskatchewan people. Our vision is optimal health and health care for everyone, and our mission is to accelerate improvement in the quality of health and health care throughout Saskatchewan. We do this primarily through building quality improvement capability, connecting people and ideas, measurement, research, and evaluation, and creating environments that enable collaboration. Before we get going today, I want to take a moment to acknowledge that we're joining you today from HQC's offices, which are located in Saskatoon on Treaty 6 territory and the traditional lands of the Dakota, Lakota, and Nakota, and the homeland of the Métis people. As an organization, we serve the entire province of Saskatchewan, which also includes, in addition to Treaty 6, lands in Treaty 2, 4, 5, 8, and 10 territories. We pay respect to the treaties that were made on this land and acknowledge the harms and mistakes of the past. We are committed to moving forward in partnership with Indigenous nations in the spirit of reconciliation and collaboration. And when we consider our topic for today's discussion, moving forward in the spirit of reconciliation and collaboration, for me, means that we must consider and act upon two very important concepts: equity and cultural responsiveness. When we introduce new delivery methods like virtual care, we must ask ourselves, are the benefits of virtual care benefiting all equally? How do we know? What changes can we make to improve equity? And does the care we provide virtually respect the patient's culture and make a meaningful effort to incorporate both cultural and medical knowledge and practices in their care? How do we know? And what changes can we make to improve cultural responsiveness? As we listen to our panelists today, I encourage us all to keep these concepts front of mind to help us all use this exciting new innovation in virtual care to accelerate improvement in the health and health care for all peoples in Saskatchewan. Just want to remind everybody that we are recording this event tonight. The recording will be made available on the HQC website following the event. So what can you expect this evening? We will have 5 panelists with us tonight, 2 patient partners and 3 physicians. The moderator will be asking each of the panelists to speak to their thoughts and reflections through a series of 3 questions related to virtual care in Saskatchewan. We will also be holding a short period of time for questions and answers from all of you, the participants in this webinar, between the second and third question. We'd like to be able to make tonight's event as interactive as we can. One of the ways we are doing this is by using the platform SLIDO. You will find the link for this online application in the chat. So the chat box is located on the right-hand side of your screen. You can look there for the link. It should have just been posted. We invite you to submit your questions during the event, and we'll draw upon these during our question and answer session. Questions that you put in Slido are anonymous unless you choose to leave your name, of course, but that's totally optional. You can also vote or like questions. The most popular questions will be ranked higher. We suspect some themes will emerge in these questions, and we'll do our best to group similar questions together and address those that are most voted on during our Q&A portion, because of course we will have limited time for questions. So we'll try to get to as many as we can, starting with the most popular ones first. So that's one way you can interact with us during the session. The other is by using the chat function, which I've referenced a little bit earlier. So to do that, if you kind of hover your cursor near the bottom of your screen, you'll see a bunch of little bubbles down there, like the ones on the slide. If you look at the little speech bubble and you click on that, that's your chat function, and that'll launch it. When you send your comments, please be sure to send it to everyone or that we can all see. And if I can ask everyone just to be sure to mute your lines if you're not speaking, just so we don't have any background noise. Thank you. You'll see underneath that there's a Q&A box. We are not using that function tonight, so please enter all of your chats into the chat box. And one last way to interact with us during the session, if you're a Twitter user, please feel free to tweet during the session. Our handle is at HQCSask, and you can use the hashtag virtualcaresask, SK, both of which are shown on the screen. So we encourage you to share your thoughts on Twitter as well. So let's just give the chat function just a little bit of practice. If you could activate your chats and just let us know real quick where you're joining us from tonight. Excellent. Moose Jaw, Saskatoon, Prince Albert, Regina, Winnipeg, Whitehorse, Quebec, Luceland, excellent. From all over Saskatchewan and Canada as well. That's really exciting. The Cottage, lucky you. Excellent. All right. So I think we've all figured out how to use the chat, and now that we're all warmed up, we'll get started with the content for this evening. So we're here tonight to talk about our experiences with virtual care in Saskatchewan, particularly over the last several months as our province has had to adapt to the COVID-19 pandemic. On the slide, you'll see a definition of virtual care, and that was created by the Virtual Care Task Force, which was made up of the Canadian Medical Association, the College of Family Physicians of Canada, and the Royal College of Physicians and Surgeons of Canada earlier this year. And they did this to develop strategies and recommendations for promoting the delivery of publicly insured medical services through virtual means. Now, we all know virtual care is not new. However, the COVID-19 pandemic has resulted in very rapid uptake over a very short period of time, as our health system has worked to adapt to our changing circumstances. There is much we can learn from these experiences to improve as we go forward. What this definition says to me is that virtual care is not a rigid concept. It can adapt to meet changing needs and circumstances, and its purpose is to maximize the quality and effectiveness of patient care. And that's why we're interested in this topic and what we want to focus on today. How does virtual care impact quality of care for patients and their families or support persons? And what can we learn that will help us to use this important innovation to continue to improve quality? Now, we also know that quality itself is like a gem. There are many different facets, or they're often called dimensions, that define the quality of a particular service. These include safety, effectiveness, patient-centeredness, timeliness, efficiency, and importantly, equity. We are hoping to explore all of these facets with our panelists this evening. And so with that, I'd like to introduce our moderator, Stephen Lewis. Stephen is a Canadian Health Policy and Health Services Research Consultant, Adjunct Professor of Health Policy at Simon Fraser University, and Clinical Professor at the University of Saskatchewan. He thinks, reads, writes, speaks, and occasionally teaches about health and public policy, distributive justice, factors that influence individual values, choices, and behaviors, and what makes systems work effectively. He currently lives in Melbourne, Australia with his partner who got a job offer she couldn't refuse. Welcome, Stephen. I'm going to pass the controls over to you now so that you can facilitate the discussion and advance the slides.
Thank you very much, Tracy. And I think it's very creative of the organizers, excuse me, to walk the talk of demonstrating a webinar about virtual care by going to the ends of the earth to find a moderator for the session. So 10 out of 10 for that. And you'll be pleased to know from the standpoint of comprehension that I have not acquired an Australian accent. And not that you care, but I am wearing pants just in case you're wondering about whether or not this pandemic and doing everything virtually has completely reduced my standards sartorially. We have a wonderful panel assembled for this event, and before I introduce them, just as a general introduction to this topic, as we all know in healthcare, the natural state of change is pretty slow. It's incremental. We add the thing here, jettison a thing here, but the pandemic has changed everything. And what it has changed most rapidly is the pace of change. It's accelerated adaptations. Virtual care is not a new phenomenon. There are places in the world, such as the Kaiser Permanente system, where prior to the pandemic, 60% of all patient encounters were virtual. There is a large literature on the subject, but it has been relatively slow to penetrate Canada. Well, along came COVID-19, and now everybody's doing it, not least because there isn't much choice these days. So we have a wonderful opportunity to explore the early days of virtual care. We have 3 physicians, 2 patient partners to review their experiences, and as indicated by Tracy, we will be posing 3 questions to them about their experiences, what surprised them, and importantly, what is the way forward based on our experience today. So let me introduce our panelists. We have Dr. Paul Acheampong as a specialist physician in general medicine, hypertension, and stroke medicine, clinical pharmacology, and therapeutics. And also, he has done some research on the topic, local research on virtual care among physicians. So I'm very much looking forward to Paul's contributions. Heather Dick is a patient partner with the Saskatchewan Centre for Patient-Oriented Research, or SKIPPR, and the Saskatchewan Health Authority. Welcome to Heather. Gordon Meyer has been a patient family advisor with the Saskatchewan Health Authority for the past 3 years. Dr. Ida Mendez is the Fred H. Wigmore Professor and Provincial Head of Surgery at the University of Saskatchewan and the SHA, and has been a pioneer in telemedicine, remote medicine, and the technologies we are talking about today. So welcome to you, Ira. And finally, my friend Janet Tutusis is a clinical associate professor at the College of Medicine in Saskatoon, a practicing physician, and has assumed a number of leadership positions in developing primary care innovation in the province. So welcome to you too, Janet, and great to see you again. So let's begin, and we'll do it in the order that we introduced them is. So our first question to the panelists is just give us a little overview of your virtual care experience. What actually has been the experience of getting into this mode so rapidly? What are your early takes from it? So over to you, Gordon. Excuse me, Paul.
Hi, thanks very much, and good evening to everyone. Great to be on this panel, sharing our views and with the audience as well. So just to set things in context, just a quick opening remark. We all know the traditional office visit, you go, you see your doctor, they examine you, they may order some tests. Traditionally, we have placed a lot of value on the history because that is where most of the information is, because that will direct what you do in your examination and your test as well. So we place a lot of emphasis on that. And I'm mentioning this in the context of what happens in virtual care, where essentially you are left with a history, you cannot examine the patient by and large, and then you may be able to order some tests. So I must say, virtual care drives essentially on just the history that you get from a patient. And as has been mentioned earlier on, pre-pandemic, the one experience dependent largely on your practice. I know in some specialties they did some virtual care, for example, some stroke medicine, but for a general physician, a general specialist physician working in the hospital and in my office, I literally did not do any virtual care in the true sense of it. Occasionally, you may call a patient to relay some blood results and reassure them, or INR for their warfarin and adjust their warfarin dose. That was it. And then comes COVID and the table turns upside down, that you are essentially seeing everyone from using virtual care. And that is where the essence of what I said earlier on comes in, that literally it's just the history that's driving it. And from my experience, with the COVID use of virtual care. I would say it was a means of providing outpatient service for both new and follow-up patients. And it made it possible for one to be able to assess the complaints and further evaluate the patient's complaints. And then from there, one was able to, if you like, reassure the patient or organize some tests or some assessments from which, if you need to arrange follow-ups or move on to do any treatment, or for some reasons you want to bring the patient in, you could do that. But for most of the patients that I saw at the peak of the pandemic, say from middle of March to middle to the end of June, I did virtually in my office, just virtual care. I didn't bring any patients in. And it worked very well. And it surprised a number of us. Some of the issues that we encountered, we may be able to discuss in the subsequent sections, but it was quite an enlightening experience that opened both physicians' eyes as well as the eyes of patients to this new modality, or not necessarily new, but the expansive use of virtual care during the pandemic, and it was well accepted.
Over to you, Heather.
Sorry about that, I had camera problems. Hi, I'm Heather Dick. During the pandemic, I had multiple telephone conversations with my family doctor, and it wasn't the first time we had chatted on the phone, so it wasn't a totally new experience. But I did have one new one, and that's a Zoom post-op physiotherapy sessions. My physiotherapist had just started working on a shoulder surgery that I had done when everything shut down, and she said, we've got to keep you going somehow. So we ended up doing Zoom, and we'd discuss my progress, we'd review exercises, and she would watch my technique on some of the exercises, and I'd watch her try and show me what to do. So we had a few glitches in there, but we did carry on. Pre-pandemic, though, telehealth appointments with my neurologist have gone on for a few years, and my parents were part of the Rural and Remote Memory Clinic in Saskatoon, and for about 10 years, we did telehealth follow-up appointments with them in our nearest close city, which is half an hour away, versus 2 hours away, taking dementia patients to the larger center, which was very confusing and very hard for them. So it's been around a long time. We've just had to up the ante a little bit.
Great, thank you, Heather. And now over to you, Gordon.
I would like to thank everyone for their time and for allowing me to discuss my experiences within the healthcare system. COVID has caused us all to become more aware of our surroundings and has brought us into a new era of how and why we need to change the things that we were taking for granted only a few months ago. Before COVID, I only knew that I had to see my doctor and therapist. Now I utilize virtual care almost every other week in one form or another, from physio treatments to health matters. I live about 3/4 of an hour from any health facility, so to drive to the closest hospital for 30 minutes of physio treatment or analysis was just tough on me emotionally and monetarily. I have had so many operations on one of my hips that I was told I would never walk without a cane. So follow-ups with my physiotherapist is very important to me. I also have several health issues that require me to monitor my blood pressure and density. So it was important that I have communication with my family doctor on a monthly basis. Just a couple of months ago, my physiotherapist had me take some pictures of my legs, and she noticed I had large indentations from my socks. I had my last hip operation in September of last year, so I thought that the swelling was normal. I had not noticed that the swelling in my other leg had also increased. She had my doctor phone me, who looked at the pictures of the swelling, and I was diagnosed with peripheral edema. I was prescribed compression socks, and I'm going in for updated heart tests. All that was done within 2 10-minute sessions. It is my opinion that while some tests that have been done in healthcare facilities has not changed, the way we get to those tests has changed for doctors, the staff, and the healthcare system on the whole. It appears to me that it's now easier to get appointments with doctors, thus the delivery of care is faster, and follow-ups are so much easier to keep track of. One of the biggest issues that doctors and their staff have is the number of no-shows. It is now normal for everyone to keep their mobile phone on them. So even if we forget an appointment, the doctor is still able to get in touch with us at the prearranged time, which I feel will help lower the statistics of those no-shows. All in all, I think that the COVID has made it much better for us in the way we do healthcare and how important it is to us. I just wish to thank everybody for their time. Thank you.
Thank you, Gordon. Over to you, Ivan.
Can you hear me, Stephen?
Yes.
Thank you so much, and I thank the organizers and of course my fellow panelists. So I've been involved in the issue of virtual care for almost a decade. I started in neurosurgery in Halifax, where we established a telemedicine service to assess head injuries in Cape Breton. And then the new technology came called remote presence robotic technology, where we use these robotic systems not only to allow us to assess patients, but also to be able to examine them using peripheral devices, as well as being able to use some of the devices of the robot itself, for example, to listen to their chest, doing an electrocardiogram, looking at their ears using digital otoscopes. The first deployment of this system was in the community of Nain, Labrador, a really remote community in Newfoundland and Labrador. And this first experience allowed us to really test the ability of this technology to not only deliver primary care, but it was useful as well for psychiatric care, and even during the time we work in Nain, 2 resuscitations were made remotely by emergency physicians in Happy Valley, Goose Bay to Maine. In 2013, I moved to Saskatchewan, and this was a specific move from Halifax because I felt Saskatchewan fulfilled very important characteristics to deploying virtual care and really enlarge it and scale it up to a whole province. We had a big territorial extension with populations that are remotely located. We have about 1.3 million people. So we felt that it was feasible to be able to start scaling up virtual care to see its effectiveness in a large territorial extension. So I moved to Saskatchewan in 2013, and with the help of the University of Saskatchewan, the Saskatchewan Health Authority, and the Ministry of Health, we started a program for the whole province. And we have now focused on vulnerable populations, underserved populations, mainly in northern Saskatchewan, taking care of acute pediatrics. We have established robotic ultrasonography to do robotic ultrasonography for prenatal care. And during the COVID time, this was extremely useful as we were able to deploy one of the systems to La Loche, which was an area of an outbreak, which was sealed because of the outbreak. And during that time, we were able to do 30 robotic prenatal ultrasonographies for pregnant women. So I'm very enthusiastic about the developments with COVID-19 and how this has potentially allowed us to decrease some of the barriers for virtual care, such as the remuneration barrier, jurisdictional issues. And I'll be happy to continue to talk to that as we respond to other questions, as I see that my time is up.
Thanks, Ivan. Finally, Janet.
Thank you, Stephen, and welcome and thank you, everybody, for attending tonight. I'm quite excited at the opportunity to be a part of this discussion, and I'm pretty confident that Stephen's going to expertly facilitate a great discussion this evening, so I hope to learn from everyone on the call. My personal experience with virtual care, again, like Tracy had mentioned early on, there's many forms of virtual care. It can extend from a simple phone call to the advanced stuff like Dr. Mendez just shared with us. The greatest advancement for me, however, was basically the revision of regulations and the fee codes to allow virtual care. So like Stephen had alluded to prior to getting started was, all of a sudden the COVID crisis removed significant barriers that allowed for this advancement in care. For many primary care providers, just in case I'm a family physician, so in a matter of a day, we converted to 100% virtual care while maintaining capacity for necessary face-to-face visits. And this was important because there are those patients who require a face-to-face visit, and creating a safe environment and security for them to know that they were safer coming to the clinic to get what they needed than they were going out to get groceries or fuel was quite important. We connected early on. We connected with EMS, home care, palliative care. We implemented 24/7 team-delivered care over the course of a couple of days. The physicians were empowered by the ability to reach out to patients. We always were paralyzed by the idea that there was no fee code for it. There were safety concerns. And so the idea of initiating a visit with those people we wanted to see typically was asking your MOA to call them and have them come in for an appointment, which was less than ideal. We took access into our hands as providers, and we contacted our at-risk individuals to inform them of the services that were still available to them. We provided information on healthcare directives for those who wanted the information. We supported them to complete those forms for those who felt it was important, and we guided them through the red envelope process. For the first time, people didn't have to come in for clinic lab results to initiate treatment or to ask questions. And I heard from Gordon and Heather, and I was very appreciative to see that other side of things. And I'm almost out of time. I'm out of time. Already incorporated e-health records, so many people had access to their personal health records in their home. The access opened up for us. We could call people back typically within hours. People were getting personal care from their providers. And so in Saskatchewan, along with a lot of places across the globe, looking for primary healthcare transformation. We talk about incremental change. We talk about, where can we go? So my N of one observation is that virtual care can be a transformation in the care delivery for primary healthcare. Thanks.
Thank you, and thank you to all the panelists for that great opening. We're now going to move on to question 2, which is what surprised you. And just by way of intro, again, the Saskatchewan Medical Association did a survey of its members, and a couple of hundred or so, in my recollection at least, responded. And there was quite a rich diversity of things that surprised them on both the positive and the perhaps less positive aspect of virtual care. And as we set up towards the ultimate conclusion to our panel, which is the way forward, I think these early experiences may help us refine what the best thing to do is in which circumstances. So let's move on to what surprised. And again, we'll begin with a patient perspective on this one. So why don't we start with Gordon this time?
Okay, thank you. Telehealth or virtual healthcare is making access to health care way more convenient through smartphones and tablets and computers. It was just a few months ago, many of us knew little of telehealth, only hearing about telemedicine or long-distance patient care. Virtual care allows for a broader variety of services 24 hours a day, saving hospital and clinic expenses and saving the patient their time and travel costs. COVID, being a deadly epidemic, has caused healthcare to adapt to new methods of treatment, bringing more of us into the 21st century. Yet telehealth has been around for over 8 years. I was amazed to discover that. I like the fact that I no longer have to travel on my own time to see my physiotherapist for treatments or my family doctor to fill prescriptions. Follow-ups I find are very easy, and quick adjustments to medicine or care can be done immediately, while taking pictures and or videos of issues is easy and safe. I personally love virtual care and have not had one issue. Matter of fact, there have been times when I would go to the doctor for a variety of things, only to forget something. Now I'm not so embarrassed to make a list prior to a phone call. While certain tests and visits are still required and are on the increase, I feel that this will help in catching many diseases in earlier stages because it is harder to take things for granted. I know of many people in the past that have gone in and been diagnosed with one thing only to find out that they have cancer or another disease and end up passing on because treatment was not provided early enough. I'm hoping that because COVID has shown us how important virtual care is, that care providers can brainstorm on how to include other things like the results from x-rays and CAT scans. In conclusion, I personally do not see any downside to continuing to expand virtual care.
Thank you, Gordon, and it's great to hear that your experience has been so entirely positive. Let's move on to now an initial physician perspective on this, and I'll turn to Ivor here. You've been at this probably the longest, although, again, there's a distinction between telemedicine and virtual care to some extent. It may or may not be fundamental here, but both recently with the pandemic, but throughout your career in pioneering these modes of care, have there been any major surprises that sort of confounded what you were expecting as you've gone through the process?
Yes, Stephen, you know, one of the things that truly surprised me, because we've been trying to introduce these higher technologies to not only our colleagues, but to our patients, was that overnight there was this acceptance of virtual care by both the public and the physicians. There was kind of a switch, a cultural switch that really indicated to patients and physicians that virtual care was not only acceptable, but it was effective. So overnight, the comfort of the patients and the comfort of the physicians to use virtual care, all the way from telephone calls, Zoom, FaceTime, and to other more sophisticated methodologies for telehealth, became a really daily tool. And that what that did, that acceptance, it actually forced, in a way, the authorities that look at the issues of jurisdiction, remuneration, to really accept virtual care as a way to not only provide care in the crisis, but that needed to be appropriately remunerated. And I think the removal of that barrier, the removal of the remuneration barrier, and to a lesser extent, the jurisdiction barrier is going to be so crucial for the future of virtual care. But I want to emphasize one issue, that virtual care will not replace the face-to-face interactions between the physician and the patient, which are extremely important for this relationship between the physician and the patient. It will become a powerful tool, though, that will allow us not only to take care of patients, follow our patients, and more specifically, distribute the care in a more equitable manner throughout our jurisdictions. So I was surprised by that sudden cultural change.
Thank you, Ivor. Now, Heather, you've been a long time patient partner, and you've done a lot of field work in the health system. I don't imagine much surprises you these days, but has anything surprised you about, following on what Ivor said, is either on the cultural front, the acceptance, or personally your own experience of it?
Not a lot of surprises, although I will have to admit, the first time my physiotherapist and I met via Zoom, I was surprised at how far we could go without her touching me, although we could only go so far. And that comes into the what didn't work so well part. But what worked well was the risk-free contact with a health provider, sitting in my own home, not having to go out at all. That was wonderful. No travel. The closest doctor to me is half an hour. Closest specialist is about 2 hours. Same day consults with my family physician were wonderful. I was used to waiting a week or two, unless it was urgent, to see him. And because my physiotherapist wasn't seeing very many patients, I could book an appointment with her at my leisure rather than at her schedule. Pre-pandemic, we had done a lot of work with specifically neurologists, with my parents and with myself. And with my parents in particular, the whole concept of not having to drive to the big center, not having to have them wait in a place that was unfamiliar to them while I tried to park the car, since they both were not happy in that type of situation, it just made life so much easier. And there were some challenges, though. My physiotherapist and I got to a certain point with our virtual hands-off approach, and then when she could finally get some hands-on again, I progressed much quicker. She needed to feel the shoulder, she needed to hear it click or feel it crunch or whatever it was she was doing, and my progress was much faster once we could have some hands-on. We didn't need all hands-on, but we needed some. And like the previous speaker said, it's a combination. You can't replace in-office visits, but you can definitely supplement them or do part of them or a combination thereof. Telehealth did cause me some issues a while ago. When a patient is using telehealth, they assume that their physician will be there, that they will be in the room at the right time, and that everything will run smoothly. I encountered a situation with telehealth where the patient in front of me went over their allotted time. By the time it was my turn to go into the room, my specialist had moved on to a different patient in a different city, and I was not seen. And the telehealth personnel said, well, I'm sorry, and sent me home. And it was up to me to contact the doctor's office, explain that I have not skipped the appointment, that I was in fact waiting. He was also waiting for me, but I just didn't show up. And then I had to reschedule, and it took a lot of time. So telehealth and other virtual care is important, and it works, but it's still got some bugs. There needs to be a little bit of fixing and a little bit of more invested in it to make it run smoothly all the time. I think that's about all.
Great. Thank you, and thank you. And as one might expect, it's a technology, and when was there ever a technology with no glitches?
Exactly.
So turning to you now, Janet, as you said, you went 100% overnight, as was the imperative. I'd like to ask you to sort of focus in on, were there circumstances or issues, medical issues with patients that you anticipated would go well with virtual health care that didn't, or vice versa, or vice versa? Were there some that you were nervous about doing virtually versus hands-on that turned out to be okay?
Thank you for the question. So I think initially our group collectively sat down and in early days decided to troubleshoot and work our way through this. And there were some concerns around safety, effectiveness, patient centeredness, and in our care with things like chronic disease management with an individual with, let's say, diabetes, congestive heart failure, and COPD. So there was a lot of concern that the patients that we need to provide this care for, virtual just wouldn't cover it. But what we found was, for the most part, the reverse. With a few modifications and a few more frequent calls, we were able to monitor in a way that we hadn't been before. Our chronic disease management visits are coded so that you don't bill for one for 90 days, and this was restrictive and limiting. We could monitor our patients and address things almost on a daily basis, which is really important for chronic disease management. As many of you will know, if you're titrating insulin or you're taking daily weights and assessing their breathing, because there's a lot you can do over video conference or FaceTime. So that we initially thought was going to be incredibly challenging, and most physicians were incredibly surprised at what we were able to achieve. And then there was always the option to have people come in, and we had specific booking practices to ensure safety of patients coming into our clinic so that there was no heavy traffic and they could maintain social distancing. So that part was, it was surprising, and some of our concerns around safety and patient-centeredness. We have lots of examples of the opposite, and I'll give you one and try to be brief here. We created our list of those at-risk patients, and we reached out to them. And just to make sure that they understood what services were available and that we were there to support them. And I called one of my patients. She's like the spry, intelligent, fiercely independent 99-year-old. And she's so interesting. Love her. She hadn't been in for a while, so I was really excited at the opportunity to connect with her. And I had called her, and she was in her residence, and very typically, completely surprised that I had called her out of the blue, and well, like what's the occasion? She was ultimately doing well as usual, and in our conversation, I discovered that she maintained her rotary phone, and she almost made me cry because she said, "I haven't been in to see you because you changed your phone system, and I have to press 1 in order to get your receptionist." So I haven't been able to access the care that I typically do. I would just, call the walk-in clinic or go there. So from, that perspective, reaching out and really understanding, individuals in their home environment, huge improvement in safety factor and quality of care. I did give her my direct line as well as my office manager's direct line so that she didn't have to press 1 to get in. And so, we averted issues there. The the challenges that we recognized was, with all these advances in virtual care and all the positive surprises, it did highlight that, with regards to equity. So in some respects, it advanced equity, it advanced patient-centered care, and it advanced effectiveness. And then in some cases, so for example, a diabetic male who lives on reserve and is reliant on medical taxi services was no longer confined to that he was 15 minutes late or his taxi didn't show up. This individual had a note on his chart, he'll be seen whenever he gets here. But that barrier was removed for him. So from an equity standpoint, it improved things somewhat. But we had advocated for a landline for this individual through social services 2 years back. And so it got me thinking, it advances equity for some, but it furthers the gap for others, because your homeless population and those without access to communication are at a significant disadvantage, and they remain at a significant disadvantage. So this movement to virtual care has really highlighted that direct relationship with social determinants of health and healthcare.
Thank you, Janet. And we're going to get into that as a key area of the equity issues shortly. And finally, Paul, any big surprises, positive or negative, in your experience thus far?
Thank you again, Stephen, for the opportunity to share my experience. I must say, my experience of virtual care has mainly been through my office outpatient practice. And I have only used telephone as a means of providing virtual care to my patients. And I'm at this juncture reflecting the experiences of the physician survey that I carried out, and had about 359 physicians across the province responding, and my present ongoing patient survey that I have had about 400 patients across the province responding as well. So one of the few things that surprised me, and most speakers have alluded to that earlier, it's about the overnight acceptance, because to do these things, you go into meetings, you discuss these, and then there are still concerns, but that overnight switch was pleasantly surprising. But one other thing that I would also mention, particularly from the patient perspective, is usually using these technologies, you worry about talking about sensitive issues, particularly in relation to health. And in the over 400 patients and the over 350 physicians who responded, these have not been an issue at all. No one has raised any concerns about their privacy being breached or their confidentiality being breached. And in fact, going on the back of one of the things that Janet mentioned earlier on about being able to use technology to advance some of these things, a lot of patients are prepared to do a lot of these home monitoring, blood pressure checks, blood sugar checks, whatever things that you may want them to do, take photographs and share to follow up on their rash, happily prepared to be contacted by email, by text, by WhatsApp, you name it. So that has been very enlightening and has overnight dissipated the barriers that we had anticipated. One other thing that I would also mention, which relates to benefits that accrue to patients in offering service through virtual means, is the socioeconomic savings that patients make. They don't have to travel, say, for example, the far north to Prince Albert. Some people may spend 3 days just having to come in, have their appointment, and go back. that it's all time that is lost. And in the survey, one thing that jumped up to me was the issue with parking around the hospital. That I never assumed that was such a concern to a number of patients, but it was a major thing that was highlighted, that they no longer have to come around and struggle to find a place to park or pay for the parking. And all of these are helpful benefits that are accruing to patients through virtual care. But as Dr. Mendez said earlier on, virtual care is not replacing face-to-face consultation. It's just another tool in our armory in providing the good care that physicians want to offer their patients. And I think it's a good thing that the SMA and the ministry and the SHA have all moved to remunerate virtual care as it should be to facilitate its use. One of the things that I would mention probably as the downside relates to people's availability on the use of virtual care. What I have noticed is with the relaxation in the pandemic restrictions, I am seeing a lot more virtual care no-shows because people are not stuck at home. They may be out doing their things. You may phone them. They may have left their phone in their car, and you may not get hold of them. So that may be one thing that I've noticed. And also the other thing that I would mention, which may not be the case anymore with the opening of services, but in the physician survey, what some physicians highlighted was the fact that because in-person visits were restricted and were largely using virtual care, some procedures or interventions that would normally have required, say, for example, you have a hernia, you've been referred to your surgeon. The surgeon needs to see it to plan ongoing care. All of those created delays, but thankfully with the reopening of services to a large extent, those should not be an issue. And a lot of the comments which have been made are all valid and shared.
Thank you. So now we are going to move on to the questions. Thank you to the participants, to the people tuned in for your great questions. And what we've tried to do is theme them. So apologies that we can't take them all in. But as Tracy mentioned at the beginning, one of the issues that a new modality of care raises is equity, because it is technology-based. It requires a different set of communication skills and so on. It requires, in addition to the convenience that it may bring to patients, it also brings some challenges. If you live in a rural area, it may not be possible to have high enough bandwidth to get you going. Some people may have no access to bandwidth and so on. So it's the whole issue of equity and the impact on virtual care is going to be a major part of healthcare on equity. And importantly, although we get to the conclusion about the ways forward, how to make sure that we don't have collateral damage in even further inequities caused by this possible practice revolution. So I'm going to again start with a patient partner here. Heather, you know a lot of people and patients, and you from all walks of life and so on. Do you see this as a serious issue, equity of access? And if so, anticipating perhaps the final part of the meeting, what worries you the most, and how do you think we ought to safeguard it?
Well, I have a real soft spot for the rural patient because I am one, and I have a lot of friends in the north. And if you're rural and you're remote, you mentioned bandwidth, but well, for example, my video is since cut out, and that's because it just cut out. I didn't stop it. And I'm not that rural. There's half of our province that is much further north than me, and I'm considered northern. And I think that technology needs to get to everybody. It needs to get there in a way that is culturally sensitive. It can't be thrown at people. It needs to be brought in with the elders, participation and cooperation. I think there's a lot of work to be done.
Great. So I'm going to now turn to Paul. Paul, in your experience and from the feedback you've had, any particular things that we need to do that should particularly concern us about this issue, and strategically, what do you think we ought to be doing to make sure that it doesn't disappear?
I thank you very much again, Stephen, for the question. I am quite reassured from the SHA, the ministry, and the physician group as well, because we know now the ministry and the physicians are able to reach compensation arrangements, which would be starting soon. And that, in fact, although it's labeled as a trial, they are committed to the future rolling out of virtual care. So that solves one of the fundamental issues that physicians have experienced in the past in ensuring that virtual care use was promoted. So that is reassuring, and I don't see any going back on that at this point. There are things that we have mentioned. We may have to find ways around using virtual care. For example, Janet mentioned the homeless population. Heather has talked about those who live in the far north, but we're also talking about the elderly folks among us who may have hearing impairment, visual impairment, and all of those things come in mind. And that is the reason why we emphasize virtual care may not be the be-all, end-all. The other traditional means are always there to be used, but it augments what we're doing. At this point, I do not see any going back on that. We may have to probably leverage on communication providers to see if there is a way this could be rolled out, and government has a role to play in this as well, in improving accessibility to some of these technologies, particularly considering the work that Dr. Mendes and his group are doing to be able to use this in our communities, because it has a huge socioeconomic savings as well. So it's not just the investment point. There are savings both to the government and to the patients, and those may need to be highlighted in trying to drive improvements in availability of technology for this.
Right. Thanks. And combined with what Dan had said earlier, I think that's some really good insights into the equity issues. And I'm going to now turn to another dimension of equity and sort of the appropriateness of virtual care, which again is highlighted by the people who are on as participants. And it's where virtual care has its sweet spot. So, for example, the new norm is kind of especially in primary care, is a bit of a division. There is episodic care. People come in with a particular complaint, short-term episodic visits, and then there is the increasingly common chronic care, multiple comorbidities, relationships important. In these early days, are you finding that virtual care is more appropriate, or a readier substitute, or even improvement for one category of care versus the other, or is it very much dependent on this? And again, let me turn to Ivor here about your experience, whether or not relationship-based care in particular for people with multiple chronic conditions is either helped by or a bit impeded by virtual care.
Yeah, so the issue, and I'll talk a little bit more about the specialty care individuals with chronic conditions. So one of the issues that we're confronted, as you know, is the access to care to individuals with chronic conditions or individuals in long-term care facilities or any other individual that needs special care, there may be a lag between the time that the family physician refers you to that patient to the specialist, or even if you go to the emergency room, the long waiting list there. So what we have found over the years is that, especially with individuals with chronic conditions, the ability to be in touch with them and to actually be faster in an initial assessment of that individual using virtual care, and then making a triaging decision at that time if the patient needs to actually be coming to the center and being seen is a huge advantage. We got the experience with a remote community in northern Saskatchewan for acute pediatric care. In Saskatchewan, there's only one ICU, pediatric ICU, which is in Saskatoon. And all the patients that need pediatric ICU from across the province have to fly to Saskatoon. And one of the issues has been, first of all, the ICUs are always full. The ability to quickly send transportation for these patients is difficult. And some patients have delays in that care. So when we installed one of the systems in that northern community, we were able to find that if you use virtual care, first of all, you could access the patient very quickly, almost immediately. And 70% of these children that presented with an acute problem were able to safely be taken care in their own community. And only 30% needed to be transported. And the other advantage was that you could follow up these children when they return to their community. So my feeling is that virtual care will actually allow us to provide more timely care and also will allow us to facilitate follow-up on these patients. And those patients will have better access if we use that with the face-to-face traditional care.
Great, thank you. To sort of wrap up this segment, and we might get two in, but I want to especially get Gordon involved in this. Gordon, from your perspective as a patient, do you have some emerging ideas on which kinds of issues that you think can really well be handled virtually, and those that may be a challenge and that you think that the traditional in-person consult is better?
I've heard comments that there are a number of people who cannot participate with virtual care, but there are also lots of people out there who are unable to participate with physical care due to their health and the fact that they maybe have no transportation or accessibility to transportation or things like that. I think that this is just virtual care is just another tool in this big bag that we have for looking after our increasing population. And one of the things I think that we should look at is, like I said before, is filling in prescriptions, reassessing the need for people to go and have x-rays when they've done particular x-rays in the past, or for I said medicines, for physiotherapy is like we were just saying, like everybody said, is that sometimes you have to go see the doctor in person, but there are many times that you don't have to see a doctor. You can take it on film, take pictures, Zoom meetings. I mean, I'm involved with addictions, and Zoom meetings are so popular nowadays that there are actually people who don't want to go back to physical meetings. They enjoy the Zoom concepts because of the convenience and things like that. So there are many things that we can take to the table that I think will increase virtual healthcare substantially within our health system. If that makes sense.
Indeed it did. Thank you. Great. Well, we could go on with this wonderful discussion forever. And again, thank you for submitting the questions. We can revisit some of them as we move on to our final segment, which is, again, early days, where to from here. So we've had this initial experience, as we've heard already. It seems largely positive. And more to the point, depending on the nature of these novel viruses, we may be in a world where we don't have a whole lot of option for the foreseeable or maybe the long-term future. So this is something that is firmly planted in the future of healthcare. So let's try to get some ideas about where we are going from here. And I want to give you a couple of sub-themes to think about as you formulate your responses. One of which is, do you think this is going to be the dominant method of interacting with healthcare in the future? Meaning, if it's not 100%, is it going to be the 60% like Kaiser Permanente and others have already done? Is it going to be less than that or more than that? Secondly, do you think if the future is going to be in this approach to care, do you think although it's going to be good, bad, or indifferent for quality? And finally, if you had one suggestion to make this even better than it has already been, what would that be? You don't have to address all three, and I'll ask you all three as brief as you can, even though it's a big question, and you can take different parts of it as you go through. So let's start this time with a physician, and Janet, again, give us your vision to date.
Thanks, Stephen. Well, I think vision one is continuation of virtual care is a must for primary health care. And I can only speak for primary health care because that's my experience. And in order to ensure that virtual care becomes a very important adjunct or a tool for clinicians to use in providing better care, I have to stress accountability, accountability, accountability. I'm quite protective of the utilization of virtual care in that responsible billing practices, responsible use in that utilization of this modality of care to improve quality, to improve safety, to improve effectiveness, to improve patient-centeredness. All of those things I think are very important to solidify this as a tool. I believe inherently that clinicians in general want to do the best by their patients. And I think virtual care is one more tool to allow them to achieve that best. So I guess virtual care does move the dial on a number of things, access, equity included, but obviously there's much more work to do. And so it really, again, it exemplifies this connection between social determinants and health outcomes and something as small as digital connectivity. And so, you know, where are we going from here? Digital connectivity for all citizens as a determinant of health. And it's something that's doable in a first world country, and we're so fortunate to live where we do. And I think going forward, we capitalize on the positives of virtual care and utilize it to the best that we can, maintain accountability so that it stays around in order to improve our care.
Great. And again, we will have, I think, a fair bit of time to circle back to some of these issues as we go through. Let's now turn to Heather. How's the future unfolding in your eyes?
Well, virtual care is here to stay, and I think it's really important that it doesn't get backpedaled if things ever get back to quotation marks normal. It's here, it needs to stay here, and it needs to expand. And I think the expansion will happen quite quickly in the areas that have the connectivity. But I think the priority needs to be to get all of the province on the same footprint where everybody has access. And there's a few things that have to happen, though, even with access, for it to be a workable solution. And that's translators need to be available for all people, Northerners, immigrants, it doesn't matter. If your first language is not English or is not the same language as the physician that you're speaking to, we need translators in place. There's nothing worse than miscommunications and errors because the wording was not understood. Patients and patient partners and caregivers need technical help. They need to know how to access, they need to know the questions to ask, they need to know what equipment they need, they may need help purchasing the equipment they need. There needs to be programs in place for that. Telehealth is good. In fact, it's very good if it's all working right, but it still needs some work. It's now available in my small town. I used to have to drive 30 minutes for it. Now I have to drive 4, I think it is, which is wonderful, but I'm fortunate. There's many that aren't at that place. I'd love to see in
so let me now turn to Ivor, and among other things,
pre-testing for surgery.
Sorry, Heather, I'm sorry, I think I may have cut you off because your sound had gone off. So if you have more to add here, please do. My apologies.
Just my vision, and that's that pre-testing for surgery could be done in your hometown, that you don't have to travel, that physicians could check in with their patients, chronic patients more often, just more of what's happening, but in a way that is equitable and fair and consistent. That's all.
Great, thank you. Sorry about the technical difficulties, folks. So let me turn to Ivor now, because among other things, Ivor, of course, you're a medical educator. For health science students, will health science education programs need to take a different approach to the practice of healthcare to accommodate this transformation, and how so?
Yes. So, Stephen, as many of the speakers have said, I feel that virtual care is here to stay. I think it opens this huge door to not only provide a maybe more efficient care, but I feel that in the future we will be training virtual care physicians, virtual care nurses, virtual care physiotherapists that will be very comfortable in using the technology. Technology will continue to advance, and we will be able to do things that are unthinkable now in the future, and potentially be able to examine patients using systems such as haptic feedback and all of that. But I think what we need to be careful as we train the physicians of the future or the nurses of the future is to really emphasize what has been a cornerstone of the practice of medicine. And this is the relationship between the physician and the patient, and the patient and the physician. This crucial relationship that allow us to be effective physicians, to be compassionate physicians, to be humanistic physicians, have to be complementary and maybe synergistic to the use of technology and the use of virtual care to provide really the appropriate care to our patients. And I think that the curriculum in medical schools has to be changed to be able to incorporate this new technology into the practice of the future, however maintaining the pillars of being a physician and practicing humanistic medicine.
Thank you. And over to you for your take on the future, Paul.
Sorry, I had my mic muted there. So just on the future, as has been shared by everyone, virtual care is here to stay. And I am reassured by the speed with which the government and everyone involved in making sure this works has been. So, for example, from the middle of June, when I finished my physician survey, that was a main issue. By the end of July, an agreement had been reached that the government had made significant improvement with regards to remuneration for physicians compared to how much physicians were getting with in-person visits, because that was identified as one of the limitations as to whether or not physicians were going to take up this service. So I am reassured by that. And going forward, I am looking at the government deploying its long arms and any other tools under its disposal in enhancing technology development in the field of healthcare delivery. I am thinking of, so instead of paying for a medical taxi to bring someone down to the hospital, could that pay for some data so that they can have a video consultation with their physician? That may be something that could be explored. And with regards to what proportion of care virtual care may occupy, I guess it depends on the specialty, because that would dictate a lot of whether or not this needs to be in person or we could do this over the phone. But some initial consultation could take place for the purposes of triage by virtual care. And with regards to the effect of virtual care on quality, I think it all relates to appropriate use, both from the physician end as well as the patient end. I have had a patient who has said, because virtual care is available, I don't want to come in to see you, even though that's the first visit that you would normally, as services reopen, want to do that to establish all the good things that Iva has mentioned, but the person opted for virtual care, and you cannot say, no, I can't do that. So it depends heavily on both users, physicians, and patients looking to deploy this service appropriately. And I think there is a bright future ahead of us if we use it appropriately.
Great. So now I'm going to go to some issues, and I'm going to get Gordon involved right now in this. Patient and public citizen co-design, of course, is the mantra of contemporary healthcare, but it's still an aspiration as much as it is a reality. And again, as you see this going forward, Gordon, you're a champion. I mean, obviously, what you set up to now is you're a fan of virtual care. Do you have any either concerns about whether or not this is going to be another innovation that proceeds from the tech people and the providers and is mainly designed for them and hope it works out well for you? Or are you optimistic that this presents a unique opportunity for patients and patient partners to really get their hands into the design and say, no, we like this better than this. We think this is appropriate over here, less so over here. We need visual here. We don't need it so much here, et cetera, et cetera. What if you were on the board of directors of the future of virtual care? What would you want to make sure, from your perspective, would be part of that process?
Thank you. I think one of the things that I would look at in the future would be to work maybe closer with, and this is going to sound futuristic, manufacturers. I mean, we have nowadays the technology coming down the pipe of smartwatches that can give different, your heart rates and things like this. So do we have to go to the doctor to get our pulse taken and our heart rate taken, or can we just tell them what our watch is telling them? That type of technology, I think, is going to come down. If there's a need for it, they will create it, I think, is what's going to happen. So where will virtual healthcare go? I think you're going to see things increase in leaps and bounds down the road simply because there is going to be a demand for people to do virtual healthcare in one form or another. There's always going to be the need to go and see your, doctor or physician or, physically. There's always going to be that. I mean, X-rays and CAT scans and things like this. But there are lots of things I think that can be done at home, so to speak, and just pass information on to the, your doctor, your family doctor. That's I'm very optimistic. I think, at my age, I'm not going to see this technology. But then it wasn't that many years ago, people laughed at putting a man on the moon or talking about putting men on Mars, and we're doing that nowadays. So to say that we won't need as much ways of going to see a doctor or as many reasons to go see a doctor will change, I think, as well, too.
Great, thank you. And Janet, you've got a big clinic and you've got lots of patients and from different circumstances. Do you see virtual care as enabling and promoting more co-direction of care and more participatory care? Does it empower patients more, or does it make some of this more remote? And when you think about the ongoing iterative design of how you approach virtual care, what are your ideas on how you ensure that it is truly responsive and patient-centered?
Thank you, Stephen. So absolutely. I think virtual care is definitely enabling from those perspectives. You're often connecting with an individual in their home. And I'm coming from a vantage point, a very privileged vantage point in that I am a family physician and many of my patients have been in my practice for going on 20 years. And so that relationship has really been built. And so, it lends itself to allowing virtual care to be such an incredible tool to provide care to patients. And there's something about an increased ownership I've found with doing the virtual care visits, because you're in their home. If they have the big bag of cheesies open on the table and they're talking to you about their latest hemoglobin A1C, they're less likely to say, it's not my diet. You never have to say, did you bring your meds? Oh, I forgot. And it's like, well, this should be in your medicine cabinet. I can wait. So it really is, I believe, enabling for the co-decision making, for the ownership and shared decision making with regards to medicine. And you asked me one other question. I've forgotten. Oh, you're on mute.
Great. As you and your partners, and again, you've got a good platform for innovation because you've got critical mass, you've got 10 docs, you've got a big diverse population to serve. When you think about how you roll out the technology parts of this, like you've got experience with the phone, you've got the visual, you have different patient groups and so on. Again, how much of this do you think, I guess the way to put it is sort of psychological in terms of how you approach care versus technological? I mean, how does it change in your mind how you think of the practice of medicine, or does it?
Well, for me personally, it doesn't. There's sort of direct lines of sight for me with patient care and incorporating technology. And I'm a site director for a family medicine residency program, and we're responsible for training 12, 14, losing count, oh boy, family medicine residents or generalists to provide care. And we're even finding, utilization of the PECSIP, if you will, that we receive for patient care video conferencing for learning, for teaching. And we've been able to identify improvements in teaching and learning because residents, you're in the room with the resident. The patient is less likely to look at the screen and talk to you. They're more likely to engage with the learner, and you're able to literally be the phone on the desk and provide that support and provide feedback to the learner. The learner, again, has to verbalize a lot of what they see, which has been quite instrumental, and we've identified significant gaps with individuals because they look in an ear, but if they can't describe to you what they're seeing and you can't confirm that, we need to support that. So, it's just been such a positive addition to the care that we provide. Our group has embraced it, and the experience that they have with it has been predominantly positive. But virtual care isn't a silver bullet. It's not going to fix everything that is challenging in primary health care, and we realize that. And we have residents starting. The first place we decided to start was we have residents doing a research project, and I think I threw that up on chat, looking at patient perceptions around virtual care, and so pre and post-COVID, because we had done patient surveys all along, and we have done them, but looking to see if we've actually improved the quality from their perspective.
Great. So, Paul, you mentioned that you've done pretty much telephone virtual care so far in your experience. Tell me a little bit more about where you think the limitations might be there. I mean, a lot of communication is nonverbal. You're watching, you're looking at people, you see the facial cues and so on. And also, if you move to this mode of care with a patient with whom you already have a relationship, it's one thing. But as we go along in time, if virtual care becomes visit one in a new doctor-patient or any nurse-patient relationship, it's a bit of an interesting dynamic too. So talk a little bit about that from the standpoint of a physician. Is there any part of this relationship building that you see is limiting in this technology, or do you think it's just an early stage thing if it is, and it will be overcome when we become much more of a bandwidth culture and everything is also visual?
Thank you very much, Stephen. And as has been said many times, it would not replace traditional care provision. It's going to enhance how we do things. In using telephone, in the time of the COVID, when it was practically impossible, if you like, in the outpatient service to bring people in, or because of service and space issues, you needed to provide some service. So yes, I was seeing new patients purely by telephone. But with the lifting of some of the restrictions, I am now seeing all my new patients in person, and I am following up more people by telephone or video means as we progress. So you cannot replace that relationship with the patient. That's more difficult to build just doing it by telephone. But if you've seen the person before, you phone them, so, I was expecting your call, how are you? I mean, we know the practice of medicine. Literally, if you as a physician have done your good job for the patient, you become an extension to their family. So they see you in that light. So that relationship is already there. But in building new relationships, that face-to-face connection still help? If that is not possible, then surely virtual care would fill the gap. But we cannot throw traditional means of service provision away. That is there to build some of these relationships and to provide care if virtual care is not possible.
So, Heather, you have been, among other things, a big champion for patient co-design, patient involvement. If we could describe it as the politics of patient empowerment. In your view, does the virtual care innovation give you greater opportunities? Do you see that this can accelerate some of these developments and as making patients as true partners to the extent that they see fit in co-design and plotting the future? Do you have any concerns about it?
Well, patient partners are ready, willing, and able to sit on any committee, any board, any whatever that is out there. But we are only invited to certain parts of the discussions. We are not usually invited to the boardroom sometimes, and it's getting better. We are sometimes invited only as a sounding board. We are not invited as full partners. For virtual care to really meet the patient's needs, patients need to be at the boardroom table with everybody else from the first discussion to the last discussion. And so far we're not there, but I think it's getting better.
So we've got about 3-4 minutes left before I turn it over to Tracy to conclude our session today. And I'm going to ask you a tough question, all of you, and I'm going to make you kind of vote and name some numbers. So it's 5 years from now. In your view, what percentage of patient health system encounters will be virtual? And secondly, do you think overall, on balance, it will either positively, negatively, or have no effect on the quality of care that is provided? So let's start with Ivor.
Well, Stephen, I may go to maybe a little longer into the future, maybe 10 years from now. I truly believe that 10 years from now, virtual care is going to be a fundamental part of how we practice medicine. It will be the platform upon which hospitals may become smaller in the future, and only patients that need hospitalization will be able to go to the hospital. I feel that within 5 to 10 years, at least 50% or more of the interactions between physicians and patients will be through virtual care. I feel it will allow us to deliver more equitable, more timely, and more cost-effective medical care. The status quo is unsustainable. We have overcapacity of our hospitals all over, especially tertiary care hospitals. Patients wait a long time to see their physicians. The cost of healthcare continues to rise, and now are about 50% of the budgets of the provinces. So I feel that virtual care will have an impact on that. It will allow us to deliver a cost-effective, timely medicine that overall will be able to provide a better provision of medical care to our patients. So I'm very optimistic about the future.
Thank you. Gordon.
Thank you. For me, I would say I would have to agree, 50% at least. And I feel that there will be a savings to the healthcare system because of it. And like I said before, I think technology will make it so accessible that at this point in time, I don't think we can understand what will happen. I don't think we have any concepts of where the future will go. That's basically what I think.
Great, thanks. Paul?
Yeah, I'm looking at a future. I am looking at easily seeing 50% of my follow-up patients by virtual care. For the purposes of relationships, I'll bring in new patients if possible, and I can easily see 50% of follow-ups being by virtual care.
Okay, Janet.
Thanks, Stephen. You know, it's really hard for me to estimate the percentage because I think it really depends on the appropriate mode of care for the presenting condition. And so really it would be dictated by the population and their care demands, what percentage would be appropriate for virtual care and what is more appropriate for in person. But I definitely would like to see a movement for increased virtual care for the overall percentage of care, and I do believe that it's going to have a positive impact on quality for the reasons I've discussed earlier, you know, regular monitoring, ease of access, improvement of access, and some tiny movement on equity. Thanks.
And last word to you, Heather.
Janet hit it right on the nose there. It's a little hard to pick a number, but equity and access and care follow-ups and stuff. But I see a number, and I think that number is going to be high. I think we're going to see 60, maybe even 70% 5 or 10 years down the future. As long as there's some in office and some virtual, I think it's going to work.
Great. Well, thank you so much, panelists, for your thoughtful and succinct responses and thinking on your feet. It's been a great session from my point of view. And before I turn it over, thank you to the organizers for allowing me to be part of this. So I'm going to turn it back now in the last couple of minutes to Tracy and Jennifer. Take back the control over the slides. Thanks.
Thank you so much for facilitating this engaging and informative discussion. Okay, I think I've got the ball back now, so I can advance the slides. Before everybody leaves for the evening, in the spirit of quality improvement, we will be sending out a survey after the webinar. So when you close out the webinar, you will get a pop-up window that's asking you to complete the survey. You're going to get a little warning that says you're going to an external site. That's okay. Don't be concerned. It is a trusted site, and you can continue and click on that. And please fill out the survey. We do value your feedback and do really want to hear from you about how we can improve for next time. We do hope that tonight was the first in what might be a series of conversations around virtual care in our province. And don't forget, the session will be recorded and posted on our website if you'd like to go back to it, or if you'd like to recommend a friend view it as well. And so just one last slide. So to stay connected with the proven activities in healthcare in our province, we invite you to sign up for Health Clips. So Health Clips is a go-to source for the latest on quality improvement, patient safety, health system performance, and patient and family-centered care, and you can get it delivered to your inbox every day of the week. You can also sign up to receive invitations to our monthly QI Power Hour webinar series, and also follow us on Twitter and Facebook. So you can find links to all of these great things on our HQC website. So with that, I will close out our session tonight. I want to give my sincere and special thank you to our panelists tonight for sharing your stories, your experiences with all of us. We really appreciate having you with us tonight. To Stephen for moderating our engaging and informative discussion. And to my team here at Health Quality Council, who's been hard at work planning the session, monitoring the chat, theming the questions on SLIDO, and ensuring a smooth session tonight. And last but not least, thank you to all of you for joining us this evening and contributing your good questions and reflections. So with that, stay safe, stay well, and take care of each other. Thank you and good night.